My name is Lisa Brett. I come from the UK. I first became aware of FGM as an issue when I was a teacher in northern Nigeria, or equivalent of Peace Corps, and I taught woodwork, metalwork and basic electrical skills in a predominantly Muslim girls' school. But some of my girls have been cut, and my flatmate, my housemate, had been cut. And they were all from the South, and they were all from the Christian community. So I didn't know it was called FGM. I was just horrified by the practice. Years later, I was involved with a national charity in the UK called Victim Support, and I would raise the issue of FGM. We're going back 30 years. So I would raise the issue of FGM. I ended up on the European Forum for Victims of Crime, and I would raise the issue of FGM. Eventually, it started to get some political traction. It started to get some political support, and I think that's what's lacking here in the US. Somebody that's a prominent politician that's prepared to champion the cause. So it began to get some political champions supporting it. I then got involved in local politics, ended up on the local government association, and then I was nominated to chair and I was part of the founders of the National FGM Centre in the UK. So that's my history. So it's 30 years. So it's taken me 30 years to get to this point in the UK. I just feel I've gone back 10 maybe in the US. So yeah, so that's my history. I'm a consultant with the AHA Foundation. So that's everything about me. Dami.
Hello, my name is Oluwadamilola Alabi, but you can call me Dami. It's easy to remember and it's shorter. While I was living in Nigeria, I didn't really know. I know about FGM, but it wasn't anything to me. I just hear the phrase, oh, this child was mutilated. But until I think my first or second year in college, while I was in New Jersey. So I moved to America when I was 18. So I watched a movie on Netflix where a child was forced to marry at a very young age, cut fistula, was raped on the first night of a wedding, and that really hit me. Then I picked up my phone, I called my mom straight in Nigeria. I said, "Did you cut me?" And she was like, "What are you talking about?" I didn't do that. Then I was opportune to live with my family friend then, who is a medical doctor. Then I was like, "Oh, I need you to check me now." Did I get caught? She was like, "You would know." I was like, "You think so?" So that movie stayed with me for so long. I started doing research. So every paper I would write in college would be about FGM or forced marriage. I also was part of a women's program where we mentor young girls that are just coming into college about leadership programs, different things. So every research would be about forced marriage, FGM. Oh, so sorry. Then when I graduated, I went back to Nigeria for 3 months to do my internship at local clinics in the communities where I was opportune to speak to expecting mothers that were young. So WHO was also doing a project where they were trying to end FGM. So we would have talks. Some women did admit to wanting to cut their child. Some were already cut. And the law of fear was about if they're going to be arrested or not. So we would usually have them bring in their husband, educate the husband, so the husband and the wife can be on the same page while they go against their family about cutting their female child. So that really interested me. That I had that on my LinkedIn page. That's how AHA Foundation found me, and I became their campus fellow because I'm finishing up my master's degree in public health, and that also made me go into public health. I've been with AHA Foundation for about almost 2 years, but I started working on this project in December. So I'm the project coordinator for the STOP FGM network, Northside Chicago.
The AHA Foundation, it was established in 2007. It was initially established as a women's rights program, and that's the area that Dami and I work on. We work purely on in the women's rights, which looks at honour violence, forced marriage, child marriage, and female genital mutilation. So that's what we do, and we work to try and highlight, make awareness, and early intervention and prevention and empowerment programs.
What you can expect to learn today, you will learn the types of FGM practiced, where it is practiced, reasons given for the practice, Also, you're going to learn to prepare yourself to work with adults and children at risk of FGM. You also learn how to undertake a culturally sensitive risk assessment. There's a lot of information we'll provide. Also, there'll be a Q&A session at the end of each learning module, short breaks to help you digest the information. We hope you leave here today with a strong understanding of both the physical and emotional health harm that's caused by FGM. Also, the intermediate harm to the child and the harm to the woman she becomes. I'm going to hand it over back to Lisa.
What is FGM? It's the sexual assault and abuse of a child. FGM refers to the partial or complete removal of the external female genitalia for non-medical reasons. It's typically done between the age of 15, but occasionally adult women may have to undergo the procedure for cultural reasons. It's been recognised as a human rights violation by the United Nations since 1992, but we're still struggling to promote awareness of it happening in the US. The practice is mainly carried out by traditional cutters, but in some settings, healthcare providers have been known to do it, including here in the United States. The World Health Organization strongly urges health professionals not to perform such procedures. FGM is recognized internationally as a violation of the human rights of women and girls, and it reflects deep-rooted gender inequality between the sexes and its extreme form of discrimination against women. The origin of the practice is unclear. It predates Christianity, Islam, or Judaism. It's said the Egyptian mummies display characteristics of FGM. Historians claim that in the 5th century BC, Ethiopians practiced cutting women, and it was also practiced before BC in the Philippines, the Upper Amazon, and in Australia. FGM was also reportedly practiced by early Romans and Arabs. As recently in the 1950s, clitorectomy was practiced in Western Europe and here in the United States to treat perceived ailments, including hysteria, mental health problems, masturbation, nymphomania, and melancholia. So basically, any problem with women, let's cut out their genitalia. In other words, the practice of FGM has been followed by many different people and societies across the ages and the continents. There are 4 main types of FGM. Type 1, clitorectomy, removal of part or all of the clitoris. Type 2, incision, removing part or all of the clitoris and the lips that surround the vagina, with or without the removal of the larger outer labia. Type 3, infibulation, which is the most severe form, the narrowing of the vaginal opening by creating a seal performed by cutting and reprecisioning the labia, so creating a barrier for sexual intercourse or childbirth. And type 4 just refers to any other form of harmful procedure to female genitalia, including cutting, scraping, burning of the area. FGM is often performed by cutters who do not have any medical training whatsoever. Anesthetics and antiseptics are rarely used. And FGM is often carried out using kitchen knives, scissors, pieces of glass, or razor blades. Girls are forcibly restrained, and the experience is a painful, traumatic, and degrading one. If traditional cutters doesn't clean the blades used, it can also has the risk of spreading HIV.
This is a map of different places FGM is practiced. This map demonstrates how widely FGM is practiced. In some countries, the prevalence is much higher than in others. In the countries marked dark red, we know that 75% of women and girls are subjected to FGMC, but those marked in yellow is less than 5%. The green areas indicate FGM is happening only in specific local communities, and the pale blue indicates that it is a practice that's happening, but is relatively rare as a percentage of the total population. So, where it's commonly practiced, in some countries, FGM is only practiced by a subgroup, such as certain communities in India, Pakistan, Sri Lanka, and Sri Lanka will practice FGM. In Eastern Europe, communities in Georgia and Russian Federation will practice FGM. In South America, communities in Colombia, Ecuador, Panama, and Peru are known to practice FGM. And in many Western countries, FGM is practiced among migrant population from areas where the practice is common. So these are like the major places where you would expect to see FGM.
The term female circumcision has been widely criticised as drawing parallels to male circumcision, and of course there's absolutely, there's no comparison. The UN uses the term female genital mutilation as they believe, as we do, that it more accurately describes the practice from a human rights violation viewpoint. The word mutilation also emphasises the gravity of the act and reinforces that the practice is a violation of a woman and girl's human rights. In the late 1990s, the term female genital cutting was introduced partly as a backlash against the term female genital mutilation. However, important to remember that practicing countries will have their own term and language, and that can be found in your manual handout today. So you've and we ask that when you're talking to a woman or a girl who might have experienced FGM or might be at risk of FGM, that you take the time to just look up what the local term is and use the term that they're familiar with. In the US, FGM is treated as one of society's most taboo form of childhood sexual abuse. It's rarely given much attention, and yet more than 500,000 women and girls in the US are known to be at risk or to have undergone FGM. But this map shows which states have passed laws to help end FGM, but every state has women and girls at risk. The number of women and girls at risk in the US more than doubled in the recorded years of the year 2000 to 2013. The majority of girls at risk today are US-born children from parents from high prevalence countries. Currently 10 states yet to criminalise FGM, and sadly the majority of states that do have laws against FGM could do with strengthening their laws. Our website, we've graded each state A to D, and Illinois is graded as a C, and we'll explain why later. There are a number of things that could do with being strengthened here in Illinois. State legislation is necessary because it sends a clear message that FGM will not be tolerated, and it gives prosecutors the tools they need. But really, we don't ever want to use those prosecution laws. We want to get into early intervention and prevention because it's too late once a girl's been cut. But state laws are needed because that sends messaging that it sends out. In Illinois, 14,200 women and girls are potentially impacted by FGM. Of those, the Chicago metropolitan area is home to an estimated 12,000. The impacted population of Chicago is in two hotspots. The northern cluster, which includes Evanston, is home to approximately 4,075 potentially impacted females. The southern cluster is home to approximately 1,250 women and girls impacted. So for this reason, our initial FGM program, early intervention and prevention program, is focused on the northern side. The distribution of the population impacted by FGM across the northern side, you can see that it's in two areas that are dominating. The area where the prevalence is highest is in the dark orange. Including Evanston, the impacted population of FGM in the northern side account for 34% of the potentially impacted population in the greater Chicago area. While this population is scattered across the northern side of Chicago, prevalence rates seem to be highest in these two areas shown here. It's estimated that there are 2,400 potentially impacted women and girls in this area. The areas are Westridge, Lincoln Square, Northern Center, and Edgewater, Uptown, and Roger Park. Over 80% of the potentially impacted females in northern Chicago self-identify as being drawn from 6 ethnic communities: Somali, 21%, Ethiopian, 17%, Nigerian, 15%, Egyptian, 14%, Malaysian, 8%, and Sudanese, 6%. Other communities in northern Chicago include Eritrean, Iraqi, and Indonesian. This is important to know because different communities will practice different types of FGM and they will cut girls at different ages. So it's important to know what the ethnic origin in order to know when early intervention and prevention is likely to be most effective. Age and its impact on risk locally. About 19% of the potentially impacted population in northern Chicago are currently below the age of 15. Given the ethnic distribution of the population, many of these under 15 are potentially already living with FGM. Somali and Ethiopian girls are often most at risk between the age of 5 and 10, which is pre-kinder to 5th grade. Sudanese girls are most at risk between the age of 5 and 8, 3rd grade, while Egyptian girls are considered to be most at risk at the age of 9, 4th grade. So it's really important that we get into elementary schools. It's really important that we train teachers and school counsellors to be aware of FGM as a risk factor and to be able to take an appropriate risk assessment of girls so that we can intervene, disrupt the practice. You'll find this in your handout, but it's just a list, and there's a longer list in your handout, but it's a list of practicing countries practicing FGM, the age when the child is most likely to be occurred, what type is most common, and who the agent, who the cutters are likely to be, whether it's been medicalized or it's a traditional practitioner. In every society in which FGM is practiced, it's part of a wider and deeply entrenched gender inequality. FGM is often supported by both men and women, in communities, usually without question. Anyone that breaks with the norm may face condemnation, harassment, and being ostracized. It can be difficult for families to abandon the practice without support. In fact, even where the harm is known, it can be continued because the perceived social benefits are deemed higher than the disadvantages. The reason for the practice often falls into 5 categories. Psychosexual reasons. FGM is carried out as a way to control women's sexuality. By removing pleasure, it's thought to ensure virginity before marriage and infidelity afterwards. It's absolute nonsense. Evidence shows that isn't always the case. Sociological and cultural reasons. FGM is seen as a part of a girl's initiation into womanhood. Sometimes there's myths about female genitalia growing into the size of a penis, or that FGM will enhance a woman's fertility when actually it's the opposite. And then there's the hygiene and aesthetics reasons. In some communities, the external female genitalia are considered dirty and ugly, because obviously we all know that men's genitalia is so pretty. And religious reasons. Although, as I've said, FGM is not endorsed by either Islam or Christianity or Judaism, supposed religious doctrine is often used to justify the practice. And then there's social economic factors. In many communities, FGM is a prerequisite for marriage. So in societies where women are largely dependent on men for economic support can be a major driver for the procedure. Reasons for the practice. Okay, we're going to separate this into 2 parts. There's reasons for the practice and then there's reasons given for the practice. So they're not always the same. Okay, the reasons you're most likely to hear from women is it's a religious requirement. No major religion condones FGM. Yet more than half the girls and women from the countries where data is available believe that FGM is a religious requirement. Please be very aware that not all Islamic groups practice FGM, and many non-Islamic groups do, including some Christians, Ethiopian Jews, and followers of certain traditional African regions. In fact, I used to teach in Nigeria, and that's where I first came across FGM, and that was very much a Christian community. It was a Christian practice. FGM is thus a dominant culture of child abuse in the community rather than a religious practice. In fact, many religious leaders of all faiths have denounced it. And there are those that claim that there's no harm in mild forms of genital cutting. However, evidence shows that some women who have undergone the least intrusive type of FGM report feeling emotionally traumatized by what had happened to them. The confusion, the pain, the embarrassment of being held down with their genitals exposed is a horrific memory. And other women will insist that they didn't mind being cut. They're proud of being cut. They didn't mind. They think it's a good thing that happened to them. Both kinds of testimony should be taken at face value and as an honest recollection. Yet those that claim there's no harm in mild forms of childhood genital cutting often ignore the differences of experience. Not uncommonly, they claim to be speaking on behalf of their entire community, as though it was a monolith. Meanwhile, dissenters from within the communities are often ridiculed and simply silenced. The power of tradition to smother resistance can be intense for people.
We're going to discuss the Illinois state FGM legislation. Performing FGM is a felony in Illinois, prosecutes practitioners and also prosecutes parents who are complicit. But the state law on FGM don't go quite as far as we would like it. So the AHA Foundation on its website has given it a grade C, as we mentioned earlier. So the recommended additional provision we would like for Illinois to get a grade A, Illinois would allow to put a ban on vacation cutting, which when a child is taken either out of state or out of the country, they're able to report. Also would very much like to see the medical license of anyone performing FGMC revoked, and for the state to provide funding for education and outreach. Since there's nothing quite like eating perpetrators in the pocket to end the practice of FGM, we'd like to see civil action made available to victims and annual statistical reporting. I'm going to talk in depth about culture and as a defensive moment, so I'll leave that here for now. The term mandatory report is a legal term which is defined in Idaho state law. It means doctors, nurses, hospital employees are legally required to report when they observe a child being subjected to conditions or circumstances that would reasonably result in abuse, abandonment, or neglect. Mandatory reporting is aimed to break the professional barrier regarding confidentiality and cultural sensitivity. In the UK, they've mandated reporting specifically for FGM. In Illinois, while a child at risk of FGM should be covered by child protection laws, if a child has already been caught, there is no mandatory report requirement, so opportunities to save siblings can potentially be lost. So these are the reasons why we would love Illinois to adopt these laws to protect girls, and not only them, their siblings in case. But imagine you have a mother bring a child to the clinic just maybe for routine checks and you realize the child had been cut. You're not mandated to report as providers. So that practice can go on, but if there's a law that mandates you as providers to report that the child has been cut, you're able to save siblings in that family and also maybe extended family members.
Does anyone have the right to interfere with age-old cultural traditions like FGM? Well, the short answer to that is yes. Culture and tradition provide a framework for human well-being. Cultural arguments cannot be used to condone violence against people, male or female. Importantly, culture isn't static, but constantly changing and adapting. Dami is from Nigeria, where I used to live, and the most popular and traditional dish is jollof rice. Yet, I don't think any of the ingredients are actually indigenous to Nigeria. So culture changes, it moves, we all change, fashions change, everything, So culture isn't static. In the US, we believe that every child has the right to be protected from harm in all settings and at all times. Tolerating medically unnecessary procedures on girls' genitalia creates an ethical slippery slope. It begs the question, how much pain, blood, and cut clitoris is enough? And who decides? Bartering with the human rights will result in human rights violations. It's important to always respect different cultural backgrounds and religious beliefs. However, this tolerance must not continue to the point where violence, abuse, or oppression takes place. Nevertheless, tackling FGM should be undertaken in a way that is sensitive to the communities that practice it. Behaviours can change when people understand the dangers and when they realise that it's possible to give up harmful practices without giving up meaningful aspects of heritage and culture. I mean, the real thing, what we're trying to sort of develop here is cultural shift. And we're looking for a cultural shift away from the practice. And that has to be a whole community effort. You know, so you guys, we're asking you to have hundreds of small conversations. That's how you bring about a cultural shift, is informing, educating, outreach, lots of small conversations so a community makes that decision, a collective decision to abandon the practice, because that's the ultimate goal. The movement to end FGM is intended to protect girls from profound, permanent, and completely unnecessary harm. The evidence shows that most people affected in affected countries want to stop cutting girls. In most practicing countries across Africa, the practice is illegal. Globally, support for FGM is in decline. So the percentage of girls being cut in practicing countries is in decline. Unfortunately, because of population growth, the number of girls being cut isn't. So we've still got a long way to go. So why is it that women cut women? Women who cut girls are generally respected within their communities. Men will be politer towards them. They will be influencers on ethical and moral issues when most women's voices don't get heard. So it's a way of empowering themselves to have a voice in a patriarchal society. There's also the financial payment, and that's less so here, but over in many communities, NGOs have to consider the financial reward that people get for being cutters. And I think this is the most important, there's the psychological issue of when a victim becomes the abuser. Some women will have idealised the practice of FGM, believing it's a good thing to have happened to them. They become perpetrators. Questions, anyone? Yep. If you think a child is at risk of FGM, then yes. And if there's siblings, you do a risk assessment. And if you think those siblings are at risk, then yes, you'd report it, because you are mandatory reporters of child abuse. The problem is that FGM is, and I'll talk more about this in a moment, it's unlike other forms of child abuse. It's a one-off event, and it's not performed with the intent to harm. It's to meet cultural expectations. So it requires different interventions and different responses from child welfare, and when we're responding. So it's an otherwise loving family can perform FGM. So it's important to keep that in mind. It's education and outreach we need.
I would love to hear you talk more about that, because when we call for DCFS, if there is a risk, like something might happen in 6 months or something like that, they don't respond to that. They respond to something that has occurred.
Yeah, and that's a problem that that's a problem we faced. I was doing a training in Salt Lake City, and fortunately we had the right people in the room, because they were talking that there's an under-resourcing that's going on here, and it shouldn't be a question of we're going to be training the Child Protective Services and child welfare officers, because we need to put resources into early intervention and prevention. We don't, it's too late once the child has been cut. So a risk of abuse should always be reported. That's, and they should be empowered to respond to that. So we need to there's a lot of training that needs to be done in this area, because it's not like other forms of child abuse. And where I've been able to train people from child welfare, their biggest question is, this is what we should be doing, but how are we going to resource it?
At risk from, you can pull that from census data on countries of origin or
How did we come to the data?
the northern cluster of something like 4,000 women and girls at risk.
Yeah.
Is that just from data on countries of origin or ethnicity?
Yeah, what we do is First of all, if someone we take it from the census data, so it's people who self-identify as being from that community, so that shows they have a closer bond because they're identifying. We look at which generation, so first generation, second generation. By third generation, we anticipate, and we're doing some research on this, that the practice is being abandoned. So we really just look at first and second generation. And then we take the prevalence from the country of origin, and we look at the population density, and we apply that prevalence rate. So if there's only one family, then it's unlikely. And we look at, so the degree of westernization needs to be taken into account as well. So we look at the population density, how people are self-identifying, the prevalence of that rate in first and second generation. Does that answer yep, good. Health consequences. The short-term health risks of FGM include hemorrhage and infection, which can be severe enough to cause death. Cutting nerve ends and sensitive genital tissue can cause extreme pain. Infections can be spread by the use of contaminated instruments and during the healing period. If a clitoral artery or other blood vessel is cut, it can result in excessive bleeding. Shock can be caused by pain, infection, or hemorrhage. Urinary problems may include urinary retention and pain passing urine. This may be due to tissue swelling, pain, or injury to the urethra. Now, I know your clinicians aren't here today, yes? Most of you? Yeah, so we have got our training available on the American Medical Association website, which goes into more detail. And also in our handout, we have links to guidance on physical examination, etc. So, yeah. The risk will obviously be associated with the severity of the FGM, and the perinatal risks include a higher incidence of infant resuscitation at delivery, stillbirth, and neonatal death. The long-term health implications: infibulation may cause complete vaginal obstruction, resulting in the accumulation of menstrual flow in the vagina and uterus. Infibulation creates a physical barrier to sexual intercourse and childbirth. An infibulated woman therefore has to undergo a gradual dilation before sexual intercourse can take place, but it's still likely to remain painful. And in many cultures, a woman will be cut open by either a traditional cutter or her husband on her wedding night, so that sexual intercourse can take place. At childbirth, many women have to be cut again because the vaginal opening is too small to allow for the passage of a baby. Infibulation is also linked to menstrual and urination disorders, including recurrent bladder and urinary tract infections and infertility. Chronic genital infections can cause chronic pain, along with vaginal discharge and itching. Cysts and genital ulcers may also appear. Chronic reproduction tract infections may cause back and pelvic pain. Urinary tract infections, if not treated, such infections can ascend to the kidneys, as you know. Female sexual health, scar formation, pain, and traumatic memories can lead to sexual problems and obstetric complications. FGM is associated with increased risk of cesarean section, postpartum hemorrhage, difficult labour, tears, instrumental delivery, and extended maternal hospital stay. For girls, genital mutilation is a major experience in fear, submission, and suppression. The experience becomes a vivid landmark in their mental development, being pinned down, powerless to influence the event, a lack of understanding of what's happening to them, the physical pain, the perceived unsympathetic attitude on behalf of the cutters can all lead to post-traumatic stress. Social anxiety and depression are not uncommon amongst survivors of FGM. FGM can further result in a loss of confidence and trust in family and friends. It can affect the child-parent relationship, which has implications for further intimate relationships, particularly between the adult and their own children. So basically, there's nothing good that comes of the practice.
Other associated risks with FGM. FGM is only practiced in patriarchal communities in which males have dominance over females, and the domination is manifested in the values, attitudes, the customs, and expectation of society. Gender analysts have long recognized that patriarchal structure involve risk of women. The idea that girls are of less value leads to an increased tolerance towards issues such as forced marriages and domestic violence issues. This sadly has domino effect on society, producing adults with childhood experiences of seeing their mothers abused. Male complications of FGM. We rarely consider the male complications due to FGM. However, male complications do exist and include problems with penetration, wounds, infection, and psychological problems. There has only been one study to our knowledge in North Sudan. In Northern Sudan, most women are caught. The study interviewed 29 young men and 30 grandfathers. It showed the majority of men would have preferred to marry a woman who hasn't undergone FGM. When the men were asked if they faced any problems because of FGM, 72% of the young men answered yes, and 53% of the grandfather also answered yes. The fact that the wife is suffering during sexual intercourse affects decent men's ability to enjoy sex. Naturally, they don't want to hurt their wife. One of the respondents, with 34, said, "I discovered the night that my wife had a big cyst. She had undergone several operations and suffered from recurrent infection during many years. Sexual intercourse is problematic. I'm afraid she will stop loving me only if I reach climax and I can't satisfy her." So I know you've had a lot of information on how this happens in patriarchal society. And here we're seeing men who are saying they would prefer to marry women who are not cut. Because things are changing, education is reaching people, and also men understand that sex is not only meant to be enjoyed by them, they want their wives to enjoy. So I'm glad we're seeing shifts in mindset about issues about surrounding FGM, and some men are willing to marry women who are not cut, unlike in some societies where if you're not cut, you're not marriageable. So hopefully changes continue to occur. I'll pass you over back to Lisa.
So when you're actually dealing with someone that you think might have either undergone or at risk of FGM, prior to engaging with someone you believe could be at risk of FGM or a survivor, learn about where they're from, the role of women and children in that culture, the prevalence of FGM, and the framework for religious beliefs. Now, if this seems daunting, you don't worry, Google has it covered. You type in FGM, any country, and you'll get a one paragraph summary of the practice, where, when it happens, everything you need to know. So it's not as daunting as it first appears that, doing a little bit of background research. And then contextualize. Cultural practices are rarely translated directly into a new environment. So factors such as the size of the local community, the leadership, the degree to which westernization has been adopted will impact on how cultural practices are continued. Unlike I've said earlier, unlike other forms of child abuse, this is a one-off event. It's not performed with the intent to harm, but to comply with cultural expectations. Be aware that while you see the girl's physical safety as your priority, the girl herself will have a strong desire not to upset her family, not to get her parents into trouble, or to face alienation from her community. So be prepared for a range of responses. For those who suffered FGM, each trauma may look different. The trauma might be triggered by milestones such as marriage, the first menstrual cycle, or giving birth. It's very important that you don't create barriers to engagement by responding dramatically to FGM if you find it happening in a girl. While women and girls may have experienced the negative consequences of FGM, they may still value the practice and think that it was good for them. It might be the only time they've experienced violence from family, so they may well respond negatively or with ambivalence to Western interference. But for some, the realization that their experience of FGM at the hands of their family is child abuse can lead to feelings of betrayal and isolation. It can lead to a woman or girl questioning the most important relationships in her life. This is very disorientating. So we talk about services, but in almost every case, you need to be looking to refer on for counselling.
There are a few things you should always remember. Sometimes family and community members can explicitly threaten or passively coerce someone from seeking the support they need. It's important to uncover those relationships. Addressing the impact of FGM forces questions of a very intimate nature. Be gentle, be kind, make sure they know it's not their fault. For a girl, they're not going to get into any trouble. For a lot of people, they understand, for instance, if you call child welfare, they might be removed from their family. And we've all heard like stories of how foster care, a lot of children, how they're treated. Some people would rather be with their family, undergo FGM, than being removed from there. And also they can get alienated from their community, their society, where everyone turns their back on them. Imagine their parent is probably not illegal immigrants in the United States. That can happen where the child would be here and they deport the parent. So there are many issues to like consider before making a decision, and also speaking to the girl, letting her know it's not her fault, it's okay. Those are important things to consider when you're dealing with a child at risk.
In your handout, you can find the type of questions that you should be asking a girl, their mother, or the wider family. All the questions there are open-ended, encouraging conversation to develop. Familiarize yourself with these questions before you interview. So there's a list of questions to help you with. General questions for parents include, do you understand my role and the reasons for this conversation? Do you feel that cutting is part of your culture and required by religion? Has your daughter got any friends or relatives who've been cut? In certain communities, as we touched on before, FGM is closely related with certain milestones in a girl's life, such as puberty. Obtaining this information could tell you when a girl is at risk. Also explore the frequency of contact with extended family members. When interviewing a child, it's useful to have an activity, and we've put again in the handout, we have a list of activities you might want to keep in a drawer in your office, to build a relationship. There's a list of ideas in your manual, so if you don't have an activity at hand, general conversation like about likes, dislikes, families, hobbies, put the girl at ease, build a rapport. You might like to consider beginning with, has anyone explained my job to you? What did they tell you? Explain your role and ask them if anyone has spoken to them about FGM before. What did they say? Whenever you're having an interview with a girl or a family who you perceive might be at risk, always finish an interview by making it clear that FGM in the US is illegal. The reason for this is because FGM is very dangerous and can cause lifelong health problems, and it is internationally recognized as child abuse. Tell the parents and the child that you're reporting and sharing information about your assessment with colleagues and other relevant organisations to ensure the girl's safe from FGM. One of the most important things we find in terms of supporting cultural shift when you're interviewing is to talk about infertility, because a lot of cultures think that it's necessary for fertility, and actually that's the opposite. So talking about fertility is a very, postnatal risks and things is a very powerful message to get across in communities. Ending FGM is a multi-sectorial approach that brings together law enforcement, child protection, educators, medics, religious leaders, government, advocates, and survivors. Now, I heard some awful things yesterday about the local police. So that Chicago police do not have the best of reputations for being sensitive and handling difficult issues. We will be attempting to get into the police and train police officers as part of this project. So our idea is that, you know, all of these agencies should be engaged in ending the practice of FGM, and they should be trained and aware of the practice. So the approach must be holistic and always keep the best interest of the girls and women at the centre of every effort. One of the most significant risk factors for a girl is that their mother has been cut. Healthcare providers should be prepared to make appropriate referrals for girls identified at risk or have those conversations themselves. Likewise, school nurses and counsellors are also in a position to identify girls who are at risk and should feel supported and empowered to tackle the issue by making a referral. Okay, now I'm going to run through these slides after the first one quite quickly because this is all in your manual. We have various risk assessment tools. Now, the risk assessment here is a tick list for yes or no. You don't run through it as a questionnaire when you're you have an interview, and these are the questions in part of your interview and conversation, open-ended questions that you're looking to find answers to as part of your conversation. So you can photocopy these and use them over and over again. The risk assessment we have here deals with 4 different interview scenarios. When a child is at risk, for a child who has had FGM, a pregnant woman from a practicing community, and a non-pregnant woman from a practicing community. So there's different things. So each risk assessment, you're initially asked to simply consider the risk before determining if the risk is significant to warrant a referral to Child Protective Services. The first slide with a child at risk also helps determine whether there are other children in the family who are at risk. Indicators include whether if a girl has spoken about as a very special holiday that she's about to go on in a country where FGM is practiced, or if the family are isolated from accessing medical professionals. So if one indicator on this list leads to concern, you should continue the discussion, ask more questions, learn more. If the risk of harm requires urgent attention, be prepared to take emergency measures. If, by your judgment, the risk to the child is sufficiently pressing, you must, by law, refer to the police and ask them to obtain an immediate danger order. From what I hear in Chicago, I think maybe child welfare would be the better first stop. Okay, so child welfare, and ask them to obtain an immediate danger order. At the same time, alert Child Protective Services. I think we changed that from police to Child Protective Services straight away. This is in accordance with state law on reporting child abuse. Also share information with the girl's school. Now, this might be a bit controversial, but share it with the school, the family doctor or paediatrician, and include a copy of your risk assessment in that. And always make notes. Always share the information of identified risks with the parents, school thing, and document this in your notes. Keep it in your notes. Okay, any questions at the end of that?
Are these assessments created by your organization or
They have been created. I have to say, I was the chair of the National FGM Centre in the UK, where funding for FGM is so much greater, to tackle FGM. I mean, the American government has given, they haven't even given breadcrumbs of funding, to be honest. So there was a lot of work that went into these risk assessments, and Europe is, I'd say, about a decade ahead on things. So this is where those risk assessments are coming from. They're coming from Europe. Oh yeah, well you can print them off of our website, or you can, we can send out the training. Yeah.
You said inform the school.
Yeah. You inform the school counsellor. Probably would you be your best bet that you suspect there is a risk here. It is about information sharing. We are going into schools so that the counsellors are aware of the practice and what happens. It's really about getting the information out there and encouraging. The counsellor or social worker in the school, yeah. Ongoing support. Actually, you are in a really lucky position here. It's unlikely you'll currently find a psychotherapist with FGM experience. However, you're very lucky here in Chicago in that you do have a psychologist. She is going to be coming in and training mental health professionals from within the Heartland Health Foundation to be able to provide that ongoing support, because sadly she's about to retire, so there'll be nobody. But she wants to spread her experience and her knowledge with mental health professionals at Heartland, and I hope that they will in turn spread that knowledge with others. So we are trying to ensure that this help is available locally. But you're actually in a unique position that you've got one person in Chicago that specializes in FGM. There isn't that, other cities don't have that resource. So you can also contact the AHA Foundation. We're happy to, if you've got questions, concerns about referrals or concerns of what to do, we're more than happy to talk to you about that. Physical, you'll all be aware of, physical examination of a child is complex, and for this reason should only be undertaken by a qualified paediatrician. Pre-puberty genitalia in girls varies greatly in appearance and function than that of a genitalia of adolescent girls. So now the majority of girls of abused children do have a distorted body image. So it's paramount importance to reassure the child or an adult woman that her body is not surprising to you and you want her to help her to be healthy. The medical examination has an enormous potential to be therapeutic message if performed in a sensitive manner. The physical examination should identify the type of FGM and seek to identify any complications. The overarching medical evaluation should always be integrated with child protection in mind. We've provided a short briefing for child protection officers because although we're going to be going into child welfare offices and training them in appropriate responses because it's a different form of child abuse that needs different interventions. We've also provided a handout that you can, if you're making a referral, you can give them a sort of overview and briefing with our contact details on it as well, so that we can support them. So FGM is going to be quite different from other forms of child abuse seen by officers, and the removal of a young girl from an otherwise loving and supporting home is unlikely to be in the best interest of a child. At the AHA Foundation, we always welcome questions from child protection caseworkers, so please do feel free to refer them on to us. Okay, question and answers. Any questions?
Is there another agency that you guys are working with that has been able to implement these with either their mental health or their side?
We are just starting. In the we're really behind. I mean, sorry to say this, but you're really behind. You really need to catch up. You are so far behind on tackling this and creating this cultural shift. And there's so little money going into it as well. So no, this is it. Yeah, sadly. This is the start. This is the start. It's big responsibility on all you guys.
We're gonna go into groups now, and we're gonna do case studies. And the first case study is about Safira. I'm gonna give you about 10 minutes to talk amongst yourself, then we'll debrief after each case. What information needs to be gathered? What did you talk about in the group?
Is kind of where is like what family members or who in their community the idea or the pressure is to do the procedure or the mutilation, and so kind of like talking to parents first, like individually, and kind of figuring out, is this something like they feel ambivalent about? Is this something they're getting pressure from other family members about? Is this something that they believe like they would like their daughter to go through? And I think that's like kind of just to get the context of like what like the greater like kind of where the pressures are coming from and what's going on.
Yeah, thank you. Anybody else? Did you discuss something different you'd like to share with us?
I think knowing the date of the trip was one thing we wanted, because as mandatory reporters, we felt like if we could get, like if it was urgent, is she going next week? That may be more urgent than if she's going in 2 months or 3 months, you know, so that was one of the bits of information we wanted to gather.
So we're going to go to question 2. We should gather this information.
We initially, I mean, we said obviously if you can gather it from whoever can gather it. So having engaging, obviously behavioral health, if they're involved, medical provider, teacher, really who can ever gather it in a empathic
way. Yeah. Okay. Anybody else have something different?
Village, I'm sure it's some kind of approach this. So
Maybe the person or team who the family trusts. So
Should gather the information to
Yeah.
reach out to someone else.
perhaps,
Okay.
you know, I mean, even if it's in the school, but
Even if it's within the school.
just someone that the parents might feel comfortable.
Talking to. Yeah. So what professionals, institution, and system needs to be engaged?
Counselor of the school first, and the child department for sure.
Definitely, yeah.
I want to say lawyer at some point.
Yeah, depending on
Yeah.
what the conversation brings. Go
We
ahead.
had a couple of ideas, so not just like the provider visit, right, and medical provider interviewing and examining, but also like the therapist, also, and then a house of worship, because many individuals from other countries, they may maintain their own religion or they may have been converted. So like we know there's a lot of Muslims and Catholics, but then the information that I missed, but this is not something that's prescribed in those religions. And if there have houses of worship here in this country at least, maybe, and if I would assume that they don't, even if it's a Nigerian church, for example, not just a straight up, Roman Catholic church, but they may be able to support and give some guidance as to, this is not something that needs to be done. You don't have to do this type of thing. And then as a last resort, or maybe just at an initial resort like DCFS, just to get them in the loop that this is happening, because clearly nothing's happened yet, but just to kind of touch base with them and see what we have to,
Yeah, I think a lot of people were like respect religious leaders, so they're sort of authority. So if they speak to them, they're able to like listen, and maybe also if there's like context in like the religious books to back that up, that might also help to say, oh, you don't have to do this. There's nothing in your religion that says you have to do this. I think that's a great idea. How fast should they be engaged?
We said immediately, and I think what we talked about was how often leading up to the 2 months. And we said at least on a weekly basis, and also engaging the parents, but separately.
Yes.
To get their individual perceptions on FGM.
So thinking like the mom might want it and the dad doesn't. So that way the dad can be the ally and there's strength in numbers. So like, yeah, I like that. How might Safira be engaged?
We just talked about like having her as like just maintaining to be like the safe person for her that she can come and talk to.
Yes.
So yeah, leaving it there. And maybe that's the person who launches if DCFS gets involved, that's the person who has to launch it because she's mandatory reporting.
Okay.
Yeah.
Yeah. How might Safira's family be engaged to ascertain whether their plan is to have Safira undergo FGM?
Similar to like what people have shared already, like shaking it in terms of like, partnering with like people who have relationships with them, like community members that they're communities that they're part of. Because like, again, as you said, it's sort of a tricky situation, and like the trust and relationship is so important. And the teacher probably has that with the parents, or the pediatrician or family medicine provider probably does as well.
Yeah, also they might not tell you anything. They might tell you they're going for a celebration, a religious culture, and it's not FGM as we think. So if they don't open up, we don't have a way to ascertain that's what they're traveling out to go do. And the last question is, what role should the teacher play in supporting Safira, being that's the person she was comfortable speaking to?
I think the teacher should make sure she's not judgmental, not coming off as judgmental, that she's a safe person, that school environment can be a safe place for her, especially if things get really hostile at home or get really, a lot of mom and dad maybe are arguing or fighting about this or something. She needs to know that she can come to school, be a student, have her friends, she's normal, she's beautiful as she is no matter what happens, and, move forward.
Yes. Thank you very much. So this is going to do the resolution.
We actually recommend that you immediately contact child welfare in these circumstances because there is an immediate risk to the child. So we're saying immediately contact child welfare. You can contact us as well. It might be fair to assume that child welfare doesn't have any familiarity with such cases. So although we're going to be doing our best, please do use the handout that's in, to inform. So encourage them to reach out to the US State Department for guidance, as well as organizations like AHA, and use the manual so that they don't treat this as the same way as other forms of child abuse. Child welfare should then meet with the family without Safira. And only once a plan for Safara's safety has been put into place. Now, on occasions, this may mean, and this is the extreme outcome, removing Safara and her siblings from the home. But this would be an extreme outcome and should only be undertaken when the situation is critical. The family should be given every opportunity to respond positively by informing them of the laws against FGM in the US and the health risks to their daughter. The conversation should also be conducted with concrete asks from the family, such as confiscating Safira's travel documents. So it might involve disrupting their travel plans. Child welfare should then expect to engage with the family in the long term, regularly checking to ensure they're not considering carrying out the procedure in the US, and support the family in dealing with any potential community or family fallout that Safira has not, because she's not undergone the practice. Okay, this is what if she's about to leave in a week, panic. If she's due to leave in 1 week, it would be essential then to immediately disrupt the travel plan. So child welfare can apply for an immediate danger order and a travel ban for Safira. This will also mean alerting the consulate in the destination country if possible. Advise Safira, now this is something I wish all schools would teach children. Advise Safira that should her family be taking her out of the country against her wishes, and she's unable to notify authorities in advance, that she should take a metal object such as a spoon and hide it about her person. And this is another area, and in California, they've done a brilliant job on it. We need to do something about this in Chicago. Put a spoon, and then when she goes through security, that's her last opportunity to explain that she has been taken out against her will, and they can take her away for safeguarding. So I think all children should be given that information. And they've done a great job in California about training airport security staff, and it's something we'll be looking at here as part of this project as well. I just keep adding on to your job. You'll be doing this. It's very easy for me to say that, but yeah. But what if she's not a US citizen? Well, that variation won't affect what can be done for Safira while she's in this country, because the child protection laws will apply, but it does limit the ability to intervene to keep her in the US and protect her if she leaves the country, sadly. So that's that one. Yeah, an under-resourced child welfare system that doesn't have the resources is always firefighting and not doing the early intervention and prevention work that could make the biggest difference. Absolutely. And this is something this is part of the project. It's part of the work that we need to do. Yes, we do. We have a helpline. It's an email, so a helpline. So, and that's often better because people can type rather than talk for if they feel they're at risk. But also our helpline will serve you, and yeah, we often have a little bit more clout when a child is at risk to be able to implement changes. So if you contact us, we can tend to be able to work with the US State Department and make those changes happen quicker. But it's not the way it should be. I mean, it should be relying on a small charity to disrupt travel plans. But that's part of what we're here to do. Yeah, community champions, and that's one of the things that we're hoping that I was talking about this earlier in a one-to-one, that one of the things we're hoping that will come from this training is because I can't go into a practicing community and say this is wrong, and I wouldn't dream of sending a Nigerian into a Syrian community to be told this is wrong. So what we at AHA do is we train frontline professionals in the hope that some of those frontline professionals will be from practicing communities and that they will come forward as community champions. So that sort of, it's a sort of step-by-step process. Our change management process is you start with the laws, unfortunately, you need to have the laws in place. Then you start with the frontline professionals to increase public awareness of FGM, the harm that's caused by FGM, how to intervene. And then from that level of, some of the people we train will be from practicing communities. They can come forward and then we will work with them and empower them to become local community champions for change. But they will need a lot of support because they will face resistance. So, yeah. And religious leaders, it's great when we can get religious leaders as agents for change. Yeah.
In my experience, many of these families, women and children, they go to like WIC offices, women, infant, children offices for their formula and their WIC visits. Do you have like signage? Is that something to have some sort of like a flyer or signage in there just to kind of bring awareness to that issue?
We are, Dami has actually designed an information thing. I'm hoping that we can work with local universities to get it translated into a number of countries, into a number of languages. But yes, so Dami is actually producing that information that we can leave in as many locations as possible.
I did create an information leaflet. So it's just a one-pager that has everything they need. Also, where they can also refer to we have something called the state guidelines. So every state has the law. So it's easy for anyone to go into it on our website. So like Lisa said, it would be best to translate in different languages. We know they have high risk prevalence. So I can also, since I have everybody's email address, I can send the information leaflet and also the state guide to everybody. So we are well equipped. And for this case study for Nafisa, we're gonna take about 10 to 15 minutes to discuss. Then we'll debrief as we did for the first one. What cultural sensitivities should the healthcare provider be aware of before the examination?
A couple of things, from whichever country she's from, most likely male provider, trying to have at least a female provider, make her a little bit more open or trusting, or at least feel more comfortable to her. That's one thing. Going through this trauma, there's going to be some sort of posturing, body language, eye contact or lack thereof, or even her affect might be affected, and it shouldn't be judged as she's hiding something or she's not honest or not candid. Rather, she's gone through some significant trauma for her. And then the last thing I was thinking of is just to remember that even though by US laws she's an adult when she's 18, in many of these cultures, you're your parent's child until you're 90 years old,
I know.
So she may be obliged to, share with them She may have some, they're providing her food and housing and a safe environment, and she doesn't want to jeopardize that. So, she has to kind of juggle all those things, and just for her to come into your office is like a big deal for her.
Yes. Absolutely. What trauma has Nafisa undergone related to FGM? And also, what options are available to relieve Nafisa's pain right now and also long term?
I would say that some sort of procedure, laparoscopic or something, corrective surgery or exploration in that area by the specialist, again, just to identify the cause of it.
I don't know. There might be, I don't know as far as like pain goes, because I think there's probably ways to redo the anatomy, but there's probably going to be a lot of chronic pelvic pain issues after that. Maybe heat involved, I don't know, like pelvic floor physical therapy or
acupuncture. Like anyone who's had, you haven't had sexual trauma, you can have a lot of like pelvic floor muscle dysfunction, which can lead to like, a lot of issues with like controlling your bowels and bladder. And so I think that would definitely help. In addition,
also I know survivors are doing like reconstructive surgery, but like you mentioned, it's expensive. Talking to like a benefits coordinator on how to help her with insurance. These are also things we can think about.
Can I add to
Go
the
ahead.
trauma? Because one is definitely the pain.
Yes.
But a lot of times for survivors of trauma of this sort, and any type of trauma, the pain can trigger mental health trauma.
Yes.
And so I think pairing it along with behavioral health therapy or services alongside, I think, are going to be crucial in order for Nafisa to heal in a way that is supportive of her.
So we're not just focusing on physical, we're also focusing on mental, so she can heal. Thank you. Okay, we have one more. How might Nafisa's family feel about disclosure to medical providers? We spoke about that. They're still her parents, even if you're 92 and your mom or your dad is still alive, they still feel the head of the house.
My kids are still my little kids.
And how can Nafisa maintain privacy from those who might not be allies or might negatively judge medical intervention?
I think she just limit the conversation to people she can trust, whether it's healthcare providers or her therapist, not putting it on social media or gossiping about it, because unless she trusts other girls, if there's other girls who have gone through the same thing, possibly maybe sharing with them, but I think you kind of want to keep it with controlled,
Yeah, people who are allies.
You can actually help.
Anything else?
I was like, it's also possible that there could be some relief from family members if there's like going to be, there might be some fear that if they came to an American medical provider that they would be arrested or there'd be some like bad consequences that they should try to seek medical care for this. So maybe if this is something they like tried to take her to someone in their country to correct and didn't work, it might be relieving to know that like there's options.
Okay.
Yeah, and I keep falling, my background is social. I keep falling back on like the therapy piece of, I think, especially in communities of color, I think boundaries sometimes are not taught as well around conversations or privacy. And I think this is where therapy could help Nafisa process the trauma, but also understand that she has a right to privacy.
Yes.
And teaching her techniques or methods of how to reinforce those boundaries in a healthy manner. And also disclosing information to people that she trusts or can confide in.
Yeah. All right, thank you. This is going to do the resolution.
We don't have all the answers, and we're really hoping that you're going to build on our knowledge and come up with better answers. The idea is that, we provide you with this foundation, but, you improve on our information, you improve your systems, and that we, in turn will learn from you guys and we'll improve our systems and share that information elsewhere so that best practice gets shared. So please, as feedback to us where you think that actually, no, this in practice, we think this would work better. So, and we're receptive to that. So what we say is, first of all, is gather as much information as possible from Nazvira about her symptoms and compare them to the way FGM is practiced in our own country, because FGM is just one of a range of possible reasons why she's got these symptoms. So, you know, it might not be due to FGM. Consider contacting the AHA Foundation to find someone to consult with who has experience of working with FGM and with survivors, and pass on our helpline details, which is an email. Optimally, Nazvira could count on parental support. Work with her to assess the possibility of her talking to her parents. There may be some education that Nazvira will need about her reproductive system, as well as FGM. Ensuring that Nazvira has access to counselling and support service is essential. And also, if around the issue of privacy, if you do ever need a translator, make sure that translator isn't from the immediate community. Make sure that the translator is an ally. So if ever you need to interview a girl and you do need a translator, it's really important. Don't pick somebody from the same local community, and make sure that person is an ally. Interview them first. Okay, ensure that the medical provider and health insurance company are in as early and regular communication regarding any medical procedure as possible. Get in early, because it could take a long time before the insurance company won't be familiar with reconstructive surgery and everything. So the sooner you get in touch with the insurance company, the better, because it can be a long process. So, you know, we need to manage her expectations as well about how long it's going to take to get her the support that she needs, or the medical interventions that she needs.
So we're just going to go through it real quick in like 5 minutes, then do the resolution. In actuality, what right does Talanza have to her child?
It depends on how she signed over her rights. If it was actually through court-appointed, like guardianship, temporary guardianship, or actual adoption. So if it's not permanent, if it's, you know, she may have some rights.
Thank you.
Seek legal counsel.
How could Talanza assess help dealing with trauma from a sexual assault? What do you say? Therapy. Okay. Who could be leading the effort to have Talanza's daughter undergo FGM?
Maybe other family members back home, or in
the community.
Maybe the person who raped her, if she knows him, if she's in contact with him, because he's the child's biological father, possibly, he might be pressuring her. And my question was going to be, and pardon me if I'm going off on a tangent, but is this kind of like activity kind of monetized? Like the family friend who's going to take her over to the country, is he getting money for this, you know, act to service?
That's something like I didn't even consider. You might, for me, I was just thinking someone who is invested in that cultural practice, like I'll take the child back home, but I didn't think about the option of they could give the person money. Maybe that's what the person does, and takes other people's children back home and help. Thank you very much for that. How far has the family gone in their planning? So we don't know how far they've gone, in the sense that it might be a week, 2 weeks. Maybe she's going in 6 months. Nobody knows. So Lisa is just going to do the resolution for that.
Ask child welfare to apply for an immediate danger order, a temporary protection order, and emergency travel ban. It will be important that Talanza's parents are not alerted until these protections are put in place. Her rights actually will depend on if her daughter, as you so rightly said, it depends on whether the daughter was legally and voluntarily adopted in front of a judge. If the adoption wasn't formally done, then she still retains all the rights of a parent to her child. Lawyers would need to argue, if it was done legally in front of a judge, then her lawyers would need to argue that allowing the grandparents' custody wouldn't be in the best interest of the child. And as she was just 15 when years old when the lawyer could argue that it wasn't consent, wasn't voluntarily, and she can apply for a custodial order. Assuming that she is still the legal parent, it will be the responsibility to support for Tanzia and the child, possibly within a refuge, but most importantly, ascertain what the mother actually wants herself. So that's the resolution.
Thank you, everybody, for coming out today to join us for this presentation. We hope we'll be able to collaborate further, and I'll make sure to reach out to every single one of you and give you the information you've asked for the brochure and also the Illinois State Guide.
So thank you everyone very much for coming. Please don't hesitate to get in touch, either any activity that you want to continue or anything you want to build on after today or any questions that you have.
All right, thank you. Have a fabulous day.